Good morning, ladies and gentlemen. It's a real great pleasure to be here. And this invitation was something that was suddenly realized from Gigi Grisani, that is a big friend of mine. We met first time, I believe, almost 40 years ago, 40 years ago, during our formation as surgeons, of course. And this is the reason why I am very happy. The first reason I am very happy to be here. The second is that as my history in the European Hernia Society and in the hernia world in this last 25, 30 years is the reason why Gigi involved me in this preparation of this session. This session is really up to date because the bariatric surgery and abdominal wall patient very frequently they come together. And since Gigi organized this session, it was very strange because the request from the patient increased a lot in Milan. I am in Milan, in the university, and in my new hospital that is Istituto Ortopedico Galeazzi Sant'Ambrogio. It's the biggest hospital in Europe. We have 600 beds and 35 surgical theaters, 57 elevators, so a big hospital. But anyway, the request from the obese patient to realize abdominal wall repair is increased a lot since 1 year. So this topic and this session is really up to date. And when he asked me to organize the session, my first thought was, it's possible to realize in the same time this kind of surgery, because I don't do bariatric surgery. In my hospital, we have a big surgeon, a big bariatric surgeon that is Giovanelli. You are frequently, probably you know him. Dr. Giovanelli, he realized almost 1,000 procedures per year of bariatric surgery. So, and I asked myself, it's possible, it's effective to realize in the same time bariatric surgery and abdominal wall repair. So this is the core of this session that we have tried to organize in a fruitful way. Anyway, I don't want to spend more time, so I will leave the words to the moderator, that is Professor Santangelo, another surgeon that we met 40 years ago? No, 35 years ago. Thank you very much. So Mario, you can introduce the first speaker, and after that we have the discussion at the end, of course.
Thank you, Professor Campanelli. Hi to everyone. Professor Campanelli said everything about this session, so I think we can start about it. So I call Dottoressa Chiappetta, prego Sonia, who will speak about new guideline on bariatric surgery and hernia surgery. Thank you.
Thank you, Professor Santangelo. Good morning. Good morning to everybody. It's a great pleasure for me to present you the systematic review which we have performed regarding abdominal wall hernia and bariatric and metabolic surgery. This is my case mix disclosure, my consulting disclosure. You know, last year we had this important paper, this statement from the IFSO ASMBS guidelines, and one of the topic was abdominal wall hernia repair. And the conclusion was that in abdominal wall hernia requiring elective repair, bariatric and metabolic surgery has to be performed first. But we had to perform a systematic review because, there were a lack of methodology. So we had an Italian group led by Maurizio De Luca and Luigi Angrisani, and I performed the systematic review regarding abdominal wall hernia. We included all papers published by September 2022, and obviously next to the PRISMA guidelines. At the end, I included only 23 studies. We do not have so much evidence in the literature. We had 30,162 patients in it. The questions are timing of bariatric surgery and abdominal wall hernia repair, obviously the bariatric surgical procedure, how ventral hernia repair, complications and recurrence. And yeah, timing is the most important question. Should we perform ventral hernia repair before, concomitant, or after bariatric and metabolic surgery? And yeah, you see the picture of different patients, one before weight loss, one after weight loss, one after open bariatric surgery, all with abdominal wall hernias. And yeah, it's every case is different, but we want to know what is the evidence. Of the 23 studies, we included 18 studies included a concomitant ventral hernia repair, and only 5 studies presented staged procedures. Up to date, we can stage obviously with surgery, with endoscopy, with pharmacology. We have a wide armamentarium to stage. Yeah, but we don't have evidence. And the ventral hernia repair, afterwards we will hear some presentations how to perform them. So 5 of the studies were extracted from national registers, and these included 28,000 patients. So this is the most biggest number. The other studies are retrospective or single center studies, though these 5 studies are the most important one. So I want to present you. The first one from Spagnolas et al. Analyzed the effect of concomitant ventral hernia repair on surgical site infection. And obviously, concomitant ventral hernia repair is associated with an increase, but not oral morbidity. This is the first important statement. The next one is the study by Kogami et al., who compared bariatric surgery alone and with ventral hernia repair. And in concomitant procedures, you have an increased rate of composite adverse events, a higher rate of implant return to the operating room, and a higher 30-day readmission rate. I'm sorry, that's not working. Okay. The third one from Mula et al. Showed also that concomitant ventral hernia repair is associated with a higher complication rate, always statistically significant, but no significant difference in mortality. And last but not least, Moskowitz compared ventral hernia repair in the 3 time stages before concomitant and after bariatric and metabolic surgery, and they concluded that ventral hernia repair before bariatric surgery should be avoided. And the overall 10-year reoperation rate was reported to be 23% and was highest in the ventral hernia repair first group with 36%. It's really high. And Klapp, who did a great work of the MBS-equipped database, he has so many great studies, looked at concomitant procedures, gallbladder and ventral hernia repair, and he also concluded that additional procedures should be deferred if possible. This is important. You know, surgeons can do everything. I can obviously perform ventral hernia repair, gallbladder removal during my primary bariatric surgery, but we have the evidence that this is increased morbidity. When we perform staging, in the 5 studies, there was a big problem. The first problem was that not all of the patients arrived finally to the ventral hernia repair surgery. And this is a big problem. When I do bariatric surgery first, the patient loses weight, and then he do not come to ventral hernia repair, or maybe he does not lose weight, and then what shall I do? But at the end, obviously, BMI decreased, and staging works. Here's another work from Sharma with a hernia recurrence rate of 31 in primary repair, 35 in mesh repair. This is too high. And Stefano Olmi, a great Italian bariatric surgeon, prepared this algorithm for symptomatic, asymptomatic, small hernias and large defect hernias. And at the end, obviously in asymptomatic patients you perform bariatric surgery, but in symptomatic patients and emergency patients, you are quite in trouble. You have the next presentation about emergency wall hernia repair. But it's really a topic which we have to think about, which we have to discuss about, and we have to create evidence. So to conclude at the end, actually we have a high amount of heterogeneous studies, and the main of the studies evaluated concomitant hernia repair, which showed an increased morbidity. We have 5 existing national registers, no randomized controlled trial at the moment. We have a higher rate of surgical site infection, a higher rate of complications, of major complications, and an increased 30-day morbidity in concomitant ventral hernia repair. And due to a higher risk of reoperation for recurrence, it should be avoided in bariatric patients prior to bariatric and metabolic surgery. So only in an emergency situation. Thank you so much. I'm sorry for my voice. And we need a tailored approach in certified centers, as you said in the beginning.
Many thanks, Sonia.
Thank you.
Very, very, very nice presentation. And it is very strange that we are talking about this with Michele, that sometimes the numbers in the papers, in the scientific paper, are in some way against the logical way to think, of course. And this is something that is always present in both bariatric surgery and abdominal wall repair, that not always the two-way they convert in the one direction. So we will do the discussion at the end, Sonia. I believe that will be better. And so we can introduce, thank you once again.
Thank you.
We can introduce the second speaker, that is another Italian guy that is very, very well known on this field. Very nice scientific approach with a lot of paper that we have realized together. And recently on the 2 journal, the emergency journal, chiefed by Fausto Catena, and the hernia journal, chiefed by me, we have joined the guidelines for the emergency treatment. So thank you, Fabio, to be here. And please.
Thank you. I guess the green. Okay, so Dr. Chiappetta showed us the literature about the timing between ventral hernia repair and bariatric surgery, and showing that probably it's better to defer ventral hernia repair after bariatric surgery. Of course, this approach implies that the hernia can be repaired electively and that the patient is a candidate for bariatric surgery. However, not all patients are candidates for bariatric surgery. Those who are candidates for bariatric surgery may not have access to bariatric surgery, or may not be willing to have it, or even may have not considered yet to have bariatric surgery. And those who considered bariatric surgery as an option have to wait generally long waiting lists. And those who finally get to bariatric surgery have to wait a long time to achieve the weight loss necessary before having ventral hernia repair. Therefore, the problem of emergency repair of ventral hernia for an incarcerated hernia is very relevant because you can always have, you will have a large number of incarcerated hernias. And the problem is very relevant because we know that in the population with obesity, the incidence of ventral hernia is higher than in the population without obesity. It's the dimension of the defect and the complexity of the hernia are higher morbidity, higher recurrence rate, and a higher risk of incarceration in this particular population. We will not have the time to discuss here all the data about all these factors. Let's just take a look at the data about the risk of incarceration because, of course, it's more adherent to the topic of the presentation. This very nice article is a population-based analysis of almost 31,000 patients. They were followed for a non-operative management. Of course, during non-operative management, some of them had to go for an emergency repair of the hernia. And you can see here the data that shows that those who had an incarceration have an higher BMI than those who had a successful non-operative management. Same kind of data here on this large observational study. Of course, we do not have randomized studies on this topic. And this large observational study could calculate an odd ratio for incarceration of 1.03 each point of BMI. So for each point of BMI increase, we have an increase of the risk of having an incarceration of the hernia. And of course, this is it's a very high number. The other aspect that makes this topic very hot is that beside the incidence, the dimension and complexity, as I told you earlier, are higher, the morbidity and the recurrence rate are higher, and all this will imply the need of a higher expertise on in the center where the patient arrives. But for emergency surgery, it's not necessarily true that the patient will show up to your high volume bariatric center, neither in a specialized abdominal wall center. Therefore, the surgeon who faces the emergency will have to rely on, will have to make decisions based on the expertise available and the logistic available. Now, let's take a look at the options we have. So, the first option is suture versus mesh. Second options we have to consider is laparoscopic versus open. Then there are different techniques for repairing the hernia, both laparoscopic and open, and finally robotic. I will not discuss the last two because we have dedicated the presentation later, and let's take a look at the first 2 points, suture versus mesh and laparoscopic versus open. If many of you probably are thinking that suture repair of ventral hernia is an obsolete procedure, then take a look at this very nice paper published in 2002 based on French, a very large sample of taken from a nationwide register in France. It's about 11,000 patients involved in this study, and suture repair in this study ends up to be 32%. So if you think that this is an obsolete procedure, well, we may think again about this. Going into detail, you can see here this paper has been already presented by Sonia and is based on the study of patients who had both bariatric and ventral hernia surgery in 2 years. So we have concomitant surgery or stage surgery, either ventral hernia first or bariatric surgery first. And when we go into detail here, you can see that suture repair is about 40% in the staged procedure and is even 86% in the concomitant procedure. So again, this is some numbers that we have to think about. The morbidity related to suture or mesh is shown here in this particular study, and we see that the morbidity of the suture repair is higher, slightly higher in the VHR first group, but it's basically not higher in the rest of the series. Finally, the recurrence. Of course, the recurrence is going to be higher in the suture repair, and this is, of course, logical. I don't know how to go back, but one thing that I was surprised is that paper that I show you does not show figures about the percentage of laparoscopic or mesh or laparoscopic or open repair in that series. I met David, I don't know if he's in the audience today. I met David the other day and I asked him about this, and he told me that the database they used to do that paper, to write that paper, does not allow to find out who has been operated by laparoscopy or not, because there is no specific code. So there is no way to understand who in that particular series was operated laparoscopically or not. The topic of laparoscopic versus open has been addressed in the publication that Dr. Campanelli was referring to earlier. This is the Italian National Guidelines we just recently published, and we did an extensive literature review about this topic. So we referring to that particular literature review. And of course, we do not have randomized clinical trials. We have to rely on large registry study. This is the first one I want to show you. This is in 2 articles addressing minimal invasive ventral hernia repair, the impact of body mass index on minimal invasive ventral repair one, and on open surgery, the other paper. They're the same authors, same database, exactly same methodology. And comparing the 2, we can find that laparoscopic surgery reduces morbidity, and it reduces morbidity both local and systemic. Of course, the reduction in local morbidity is much more significant than systemic morbidity, but morbidity is overall reduced. This is not a paper about emergency, but it's the comparison for body mass index. However, we find in this series that strangulated and incarcerated hernia are a very large part of the series. Same result in this very large national inpatient sample database study, about almost 50,000 patients. And we see here that morbidity is lower again in the laparoscopic treated group. This work here is taken again from the NSQIP dataset, and this one is about emergency and is not about obesity. However, we'll find here that the mean BMI on this series are all in the obese range. And this paper too shows with this very large series again that the odds ratio of having a morbidity, wound morbidity, is much higher for the open group. So at this point, everybody is expecting from me some take-home messages, of course, like as in any presentation in the Congress. However, we've seen that the literature about this topic is tenuous, because there are a lot of problems with literature, and honestly, it doesn't allow me to give you take-home messages about this. So I thought to give you, instead of take-home messages, some think-about questions that can be discussed in the discussion later or in another occasion. And the think-about question I propose to conclude my presentation are basically three. Is a complex ventral hernia repair, so a component separation, a preperitoneal repair, appropriate for an incarcerated ventral hernia in a person with obesity who has not yet achieved a significant weight loss? Or are we going to burn our bridges doing that, knowing that the recurrence rate will be anyway much higher due to the BMI? Could we adopt a higher recurrence strategy as a bridge to a future definitive ventral hernia repair? Or should we go for the technique with lower recurrence rate at that moment? And could suture repair have a role? We've seen earlier the data about suture repair. I'm not supporting here the suture repair, and we discussed this in the postgraduate course at the opening of the Congress. However, the question is, could suture repair have a role as a bridge repair or not? So these are open questions and may stimulate discussion.
Compliments, a really interesting presentation. You have opened a lot of questions that I hope we can discuss after. Also about what kind of prosthetics you can use when in emergency operations. Now we are able to go on, and I call Emanuele Menzo, perdonami Emanuele, who speak about when and why we able to operate it, and I ask to respect the time because we have to respect the time.
Of course.
Okay, grazie.
Well, Professor Campanelli and Sant'Angelo, thank you so much for the invitation. It's a true privilege for me to be here and discussing this subject with you. These are my disclosures that have no bearing on today's presentation, and this is my case mix disclosure for bariatric surgery. So we all know, obviously, that bariatric surgery is increasing in numbers, and the number of obese patients continue to increase. And it's obviously logical to expect that the number of incidental hernias in these patients and the procedures done in these patients will continue to increase. And most importantly, the physical exam is unreliable. So some of these hernias are actually a surprise at the time of the bariatric operation. There is a linear relationship between BMI and the incidence of hernia that's been very well shown. But also, the obesity is a risk factor not only for the development of the hernias, but also for recurrences and complications. This has been shown in many papers, and in this nice paper from the Cleveland Clinic of Mike Rosen's group, actually the SSI and the SSI that requires interventions, you see how there is a linear correlation between the BMI and the incidence of those. And of course, the goal is to avoid this, which is the vicious hernia cycle, where you start from a hernia repair, sometimes even elective. You end up with a surgical site infection that increases the chance of recurrence, readmissions, and not only perpetuates that cycle, but results in a significant increase in the expenses. And it's been calculated that only a 1% chance of reduction of the recurrences will result in a significant save in terms of economic expenses. But more importantly is to avoid ending up like this with open abdomen and disasters that then you have to continue to take care. So what are the options? This has been eloquently described earlier by the previous speakers. So we can do medical weight loss, surgical weight loss before. I think we should add now maybe endoscopic options prior to a hernia surgery. Or we can just do the surgery at the same time, and that's the topic that I've been asked to discuss today. And finally, we can just go for a hernia repair and hope for the best. The problem, I think, is also when we find the hernia incidentally, that we are not expecting, we're not prepared for. So what do we do in that case? Are we ignoring it? That's easier to do if we're dealing with a sleeve gastrectomy or if what's incarcerated is omentum. We do a primary suture repair, like the Professor Campanile explained to us, maybe a role to that. Or we put a mesh, and if so, which kind of mesh? And that's what I'm going to try to address in the next few minutes. So the question is why and when concurrent ventral hernias? Well, the why, to me, seems like the only reason is if we're trying to avoid a small bowel obstruction or an emergency, and if you want to make sure that that's not an issue after the bariatric operation, because that could become a disaster. Obviously, having a bowel incarceration will affect the results of the bariatric surgery in the first place. And of course, there's other potential reasons which are probably not as important. The physiologic and economic impact of having 2 surgeries instead of 1, maybe the risks of anesthesia and so forth, the economic burden, but sometimes it's necessary in order to complete the bariatric operation. However, if we do the concomitant operation, we have to expect potentially more complications and possibly more recurrences. So some of these papers have been already presented, so my apologies for repeating them. I'm going to go quicker and maybe highlight some facts of the papers that have not been discussed already. This is the reason, this is the paper that gets quoted a lot of times why we try to do these procedures concomitantly, because we are concerned about having a complication of a bowel obstructions afterwards. I just want to point out that this paper had only 14 cases that were deferred, and in all 14 cases, which were gastric bypasses, the hernia that was incarcerated was reduced, and nothing was done to cover up that defect at the end. So it's not a surprise that we ended up with a 37.5 incidence of bowel obstructions afterwards. So potentially, as Dr. Dara presented later on, if we leave the omentum incarcerated, the chance of getting away of touching and not touching the hernia, the chance of small bowel obstruction can be reduced next to 0. So this is the NISQIP paper, one of the 2 NISQIP paper that reviews the concomitant procedures. To be noticed that 83% were reducible hernias, were all done laparoscopically, and of course there were higher incidence of every single primary and secondary objective of the paper. So this is definitely a clear indication that we should not combine the procedures. Regardless if this is a bypass or a sleeve, and regardless how the hernia was fixed. This is the second NISQIP paper that already has been mentioned. Similar results, although the methodology was slightly different. Same thing were in the meta-analysis, this time from BA Squip, so a little bit more live view of the bariatric operation, more sleeves than bypasses. Again, longer operative stay, complications, and more importantly in this paper, there were more reoperations, all for bowel obstruction, so something to think about. When we go down to institutional type of data, this is again from the Cleveland Clinic, 159 patients and mostly gastric bypasses, high incidence of primary closure. That in itself tells us that these were probably smaller hernias. And that's where the heterogeneity of these studies come from. We're comparing small hernias with big hernias, primary repairs with mesh repairs, biologic meshes with synthetic meshes, which of course, as Dr. Campanelli teaches us, in the hernia literature is not acceptable. So, of course, the wound infection was very low, and there were no mesh infections. Most of them were done primarily. So, again, the value of this data is really not a high level. This other paper, it's a retrospective review of 11 studies, more balanced results, again, most likely because of the inclusion criteria were not exactly what we see every day in our clinics. And finally, the French study that has been quoted already twice, which is probably one of the best evidence that we have today. And Dr. Moskowitz illustrated this paper a couple of days ago during our postgraduate course. And again, the concomitant repair had a large number of primary repair, most likely indicating small hernias. So the question is, if we have to fix a mesh, the hernia at the same time, can we use a mesh? You know, in the past, people have been using primary repairs, maybe biologic, but I think we have more data today that we can also use synthetic mesh. And this is probably the largest experience that we have available coming from India with 156 cases where there were no significant complications from the mesh itself. Yes, we might get superficial site infections, but no deep infections, no mesh explantations. And I think the best evidence in general comes from this paper, the randomized single-blinded trial from Mike Rosen from the Cleveland Clinic, where he was able to show that the recurrence with a synthetic mesh is much less than a biologic mesh. So there's an absolute risk reduction of almost 15%. No difference in surgical site occurrences that require intervention, and of course a huge difference in terms of price. Now we have to notice, however, that these were all retromuscular repair. So we have to also acknowledge the fact that not all of us will do a true retromuscular approach in somebody that has obesity and we're doing a concomitant gastric operation. This is a small study that we perform at our institution just to show how contamination really is not an issue in sleeve gastrectomies. In fact, all the cultures that were taken intraoperatively showed no contamination, whereas there was contamination as expected in a gastric bypass. So, to give you the best evidence topic, as the title of this paper illustrated, really there's not best evidence. And actually, when the America's Hernia Society and the ASMBS came together to define some guidelines or at least a consensus, we identify only one paper with level 1B evidence. So in conclusion, no consensus can be drawn at this point, and this is clear from all the other speakers that have taken the podium today. So the question that was asked to me, when to do it? Probably only when it's necessary to complete your bariatric operation. And why? Maybe to avoid postoperative bowel obstructions. But think about synthetic mesh, because if you get a recurrence and you get a bowel obstruction, you're not doing a service to your patient. Thank you again.
Many thanks, Emanuele. Very interesting presentation. Of course, a lot of questions that we have to debate at the end. And now we can introduce the next speaker, and the Dr. Saha, please. And he will talk about the possibility to do the laparoscopic IPOM, when, why, how. Thank you very much, Dr. Saha, to be here.
Yeah. First of all, let me thank IFSO for this kind invitation. And I must say the first three speakers have really given a good guide. Sorry. Can you just... Anyway, has been a good guide. And I must say, hernia, can you just help me? The slides are not moving ahead. So, and we know that presentation of hernia is variable. There are different types of hernia, different types of procedure performed by different surgeons. There is no uniformity. And when we add another problem of severe obesity to this, it becomes more complex, and that is why it is very difficult to have clear-cut guidelines. Clear-cut guidelines to define treatment for hernias. I have no conflict of interest. And Let me start by referring to the ASMBS AHS guidelines, which clearly suggest a link between hernia, obesity, increased recurrence of primary, secondary hernias. The reasons were increased visceral fat, increased intra-abdominal pressure, and increasing abdominal wall circumference, one of the reasons for recurrence as well. And some additional thought processes: in males there is reduced testosterone level, there is sarcopenia and weakness in abdominal muscle, so that's another reason. The guidelines clearly stated that combined hernia repair and metabolic surgery could be safe and associated with good short-term outcomes. So everywhere, if you look at that, the outcomes talked about are short-term. And there is a relative risk, lack of evidence for the use of synthetic mesh, even though we heard with the earlier speaker that the recurrences were less with synthetic. In patients who are not amenable to laparoscopic repair, a staged approach is recommended, and I believe that will be continued all the time. The grade of obesity does impact development, progression, type of repair, even the result. And therefore, grade of obesity is important, and I'll elaborate more on that. Weight loss is ideal prior to hernia treatment in such people, and the amount of weight loss required may depend on initial BMI, type of operation, associated condition, and whether you are planning concomitant or a stage procedure. Just a day before I reached here, a friend of mine referred a patient to me. You can see a giant hernia recurred after laparoscopic IPOM. Most of the bowel was outside, but typically the patient gave me classical history that he could feel the transfacial sutures or tackers cutting through slowly, and the hernia recurred in a year's time. So only IPOM in patients with severe obesity probably is not the best choice. Recurrences. Again, looking at a standard IPOM mesh with more than 4 to 5 centimeter overlap, 4 corner transfacial sutures, 2 rows of circumferential tacks. Nowitzki stated a recurrence of 5.5 at 25 months, but the mean BMI was 38. If you go to Raptopoulos, the BMI was 46.9 and the recurrence increased to 18.5 at 15 months. That means higher BMI, longer operative times, larger defects are associated with more of this. Now again, referring to the same paper which was quoted earlier, concomitant bariatric surgery together, the combined procedure, again, safe to have this procedure, but the follow-up was very short and the recurrence quoted was only short-term. Even for this paper on the recurrent hernia in the large series, low rate of early recurrence, and as we saw in earlier papers, as the duration increases, the recurrence increases. All these surgeons probably were dependent on the weight loss and reduction in the intra-abdominal pressure. Concomitant hernia repair, bariatric surgery, a retrospective analysis from a UK-based center. Hernias recurred in 8.47, but typically they recurred in those who were defects more than 5 centimeters, BMI, higher BMI, more females, and BMI more than 45. This is one attractive option which is coming up, ETAP, for ventral hernia, but of course as a second stage, and maybe this can be an option to IPOM after this, because in IPOM, in a larger defect, it's very difficult to close the defect. Complex hernia with loss of domain, just like this. Obviously, a laparoscopic sleeve gastrectomy followed by any standard repair is the option. You can see there were hardly any space. This patient had recurred, hernia has recurred 4 times because only hernia was treated and not obesity. Again, referring to this paper from George E., then I would focus my presentation on this thought process, where he tried to find an algorithm based on behavior of hernia, characteristics of hernia, and those of obesity. And therefore, probably the thought process algorithm should be based on favorable or unfavorable obesity. Favorable obesity is BMI less than 40, unfavorable being more than 50, gynoid or android obesity, subcutaneous fat thickness less than 4 centimeters or more than 6 or 8 centimeters, presence of abdominal wall, skin infection or edema could be additional factors. And this is another example, unfavorable obesity and unfavorable hernia. You can see recurrent hernia, scars, abdominal wall cellulitis. Definitely these patients would need a stage approach. But this is a patient favorable recurrent hernia and favorable, unfavorable recurrent hernia and a favorable obesity, BMI of just 33, 34. This patient could have an aggressive medical weight loss followed by hernia repair, but even though this patient did not qualify for surgery, in our unit, we would offer laparoscopic sleeve gastrectomy, decompress the intra-abdominal pressure, and only then offer a hernia repair, because even though the obesity is favorable. Similarly, like how I said unfavorable or favorable obesity, there are factors to decide favorable or unfavorable hernia. Midline hernias are more comfortable to treat. Defect size less than 4 centimeter or more than 8 centimeter, whether it's primary or recurrent, incisional, primary or recurrent, single or multiple in the same site or lateral to the midline, redundancy of excess skin which can give rise to collections or maybe aesthetic considerations, bowel adhesions, history of previous surgery, reducible or non-reducible, planned or emergency presentation. So all these together would decide whether a hernia is favorable or unfavorable, and a combination of favorable hernia plus favorable obesity would have a different treatment than that of unfavorable hernia with unfavorable obesity would need a stage treatment. And hence, I'm presenting a short algorithm from our unit, still not published. Defect less than 5 centimeter, IPOM with closure of defect. Sometimes we give a posterior release on rectus sheath to make the closure stronger. Favorable or unfavorable obesity, smaller hernial defects do need closure. Favorable obesity with BMI just 32 to 40, sometimes we do small incision, open extraperitoneal or pre-peritoneal inlay mesh repairs to prevent contamination. Favorable obesity, IPOM plus can be an option. As we heard earlier, any bypass procedure, history of any bowel surgery, repair of defect less than 5 centimeters is a must during any bowel surgery. Unfavorable obesity with adherent omental plug in umbilical hernia patient undergoing sleeve gastrectomy can be left at times, and we saw that 100% safety in that. Concomitant bariatric and hernia is preferred if the defect size is small. At the same time, if the defect size is more than 8 centimeters, for BMI more than 50, bariatric surgery should be the first option, or any kind of weight loss should be the first option, followed by one can choose IPOM plus, abdominal wall reconstructions, or sometimes because the BMI is high, patient may choose abdominoplasty with IPOM plus or with abdominal wall reconstruction. And defect size more than 8 centimeters with BMI less than 40, either medical or surgical weight loss, and any methods, IPOM plus, ETEP, ERS, even abdominal wall reconstruction can be used. But probably aggressive weight loss prior to hernia surgery is the important message in this. Small defects, concomitant repair is a must. Symptomatic hernia, patient unwilling for bariatric surgery, still I would say aggressive weight loss of some kind, endoscopic, pharmacotherapy is required, followed by hernia repair, and we would insist and follow the patient to follow with bariatric procedure even after hernia to reduce the recurrence. And larger defects, definitely bariatric surgery, second stage. Complex hernia with adhesions, medical weight loss, or bariatric, followed by appropriate hernia repair. In conclusion, even though I wouldn't say it's a conclusion, bariatric surgery itself is a preoperative preparation for large or unfavorable hernias. Concomitant metabolic and bariatric surgery and IPOM plus may be a safe option with good short-term outcomes only if obesity and hernia are both favorable and comfortable. Thank you so much for this invitation. And before I end,
very new concept on favorable and unfavorable. So the relationship, the ratio is very difficult to understand, not to understand, to calculate. But anyway, thank you very much. We will do the discussion at the end. Very well. Okay.
Now we change surgical approach. We speak, we speak. Dottoressa Rossana Berta, we speak about robotic approach. When and why? Prego.
Thank you for this kind invitation. And robotic ventral hernia repair is really a topic of new topic of ventral hernia. Come si fa andare avanti con questo? Ah, questo. Okay. These are my disclosure. Mini-invasive surgery is the best option in ventral hernia repair of obese patients that have a lot of complication in open repairs. And laparoscopic IPOM or IPOM Plus was the best preferred method of ventral hernia repair for the past decades. But in very obese patients can be really difficult because we have a torque on instruments and trocars because the high weight of the abdominal wall, and this can cause a really a bad operation, an imprecise operation during IPOM. So the intuitive switch from laparoscopy is to robotic use of the use of robotic platform. And the robot facilitates minimally invasive ventral hernia repair and has been used to suture the mesh to the ceiling of the abdominal wall. But all the papers that compares the robotic IPOM with the laparoscopic IPOM failed to find an advantage using the robotic approach. In this paper published by Priscilla Armiglio, that data from almost 50,000 patients demonstrates that the robotic ventral hernia is not superior to laparoscopy in terms of mortality, complication, readmission, postoperative infection. Is only more expensive than the laparoscopic approach. But after the description of the transversus abdominal release by Nowinski, last trends in ventral hernia repair are primary defect closure of the abdominal wall and mesh implantation outside the abdominal cavity. And midline reconstruction must be the goal in abdominal ventral hernia repair, minimizing the use of penetrating mesh fixation that can cause pain. And intuitively, robotic platform can help to position the mesh extraperitoneal in really a small space. It can help to work in really a virtual space, extraperitoneal space. The approach to extraperitoneal space can be done even in obese patient or transabdominal, inserting the trocar through full thickness of the abdominal wall, and we can assess to the extraperitoneal space, dissecting or from inside the peritoneum, dissecting or the only peritoneum sheath, and this is the TAPP, or we can dissect the retrorectus sheath, and this is the Rivstopa or the Tarup technique, or we can dissect more laterally, and so we obtain the transversus abdominal release. Otherwise, we can create a bubble in a virtual space between the muscles and the posterior fascia and work outside the abdominal cavity, and this is the EATP. This is a different approach. This approach, last approach, can be done, can be used by laparoscopy, but is really very difficult, as been described by Igor Beliansky and Victor Radu, and is indicated in smaller medium of the midline hernia, has no control on adherence, has a long and difficult learning curve, and is time-consuming, but is more simple to perform this kind of operation with the robot, and the application to this kind of operation is intuitive again. And studies that compare the intraperitoneal versus extraperitoneal mesh using laparoscopy have had demonstrated no statistically significant difference between patients who received intraperitoneal versus extraperitoneal in terms of surgical site seroma, occurrences, and recurrences. And this multi-center randomized clinical trial, the REVEAL trial, demonstrates that the robotic approach, extraperitoneal approach in midline and small hernias has no advantages respect the IPOM technique in terms of length of stay, pain, quality of life, or cost. So the costs are similar, but has no advantages. The laparoscopy has a better workload, surgeon workload is faster, and so the surgeon can operate more and more patients in the same, in one day. But our direct experience is that probably in midline small hernias, the robot is not has no advantages, but in lateral hernia seems really the best approach, either with extraperitoneal or intraperitoneal TAPP or E-type approach. Only with a few holes you can repair hernias, lateral hernia, that by laparoscopy you cannot, is not possible to repair. And the great advantages of using the robotic platform is the robotic transperitoneal retromuscular approach. The TARUP technique, the robotic transabdominal retromuscular umbilical prostatectomy hernia, and the transversus abdominal release. This kind of operation are made by an open approach most of the time, but with the robot, the robotic platform, you can transform this open operation in minimally invasive operation, and this is a great advantages for obese patients. The TARUP technique has been described by surgeon Philippe Moison. He has a great experience, a lot of patients treated with kind of operation, and is useful for small hernia of the midline. And the TAR is really the robotic TAR and the hybrid variation is a really advantageous technique. This meta-analysis and systematic review of Umberto Bracale demonstrates that the robotic TAR has lower complication rate, lower risk of developing surgical site occurrences, systemic complication, shorter hospital stay, respect the open approach, but has longer operative time. So seems the best option for obese patient. But the transversus abdominal release, the robotic transversus abdominal release has some limitation, can be used in patients with smaller hernia between 8 and 14 centimeters in wide, cannot be performed in patients with loss of domain, and cannot be made in patients with combined median and lateral hernia gaps, and cannot be made after an open abdomen. So our conclusion are that robotic extraperitoneal ventral hernia can be used in obese patients before and after bariatric surgery. Actually, there are not indications to use it during bariatric surgery. Robotic ETEP appears disadvantageous in midline small hernia, but seems the procedure of choice in hernias of the border, either in obese and normal weight patient. The robotic TAR is probably the best mini-invasive surgery in obese patient with hernia between 8 and 15 centimeters, but more studies are required to evaluate short and long-term outcomes. There are a lot of concern about cost, learning curves, and new dangerous complication using transversus abdominal release of this new technology. Thank you.
Very well, Rossana. During the discussion, it would be interesting to know if someone has experience to robotic approach, because this was the theme, the robotic approach, both for the bariatric surgery and abdominal wall repair. So what's the advantages and possibilities? But anyway, we have the last speaker, that is Dr. Rajesh. Please, Dr. Rajesh, very interesting, because how manage the complication, because there are not so few complications and recurrences, of course.
Thank you very much, organizers, for having me here. There is no disclosure, but yes, I work in a high-volume bariatric center at Mumbai, and most of my patients of obesity and hernia are referred by Mufisa. He is well known in this crowd. So, we know the recurrences are more in obese patients. The regions could be higher intra-abdominal pressure. I'm not going to discuss each and every step because of conflict of time, but we know these are the factors which are responsible for recurrences. Now, what are the causes of recurrences? Before we go to treatment, we should know the causes of recurrence. Number one, inadequate initial repair. Mind it, the first chance is the best chance. Every recurrence has more recurrences in future. So when you are operating in a patient, you say my recurrence rate is 1%, but think of that patient who has got this recurrence. For him, it is 100% recurrence. So it should not be taken as an easy procedure. So, and second is tension of the repair. We know the repair, the closure should be always tension-free. That's why we do myofascial facial release in form of anterior component or posterior component. Poor wound healing. Whenever there is infection, whenever there is SSI, SSO, the chances of recurrence increases. Obesity, smoking, chronic cough, lifestyle factors, genetics, post-op complication, these all are factors which increases recurrence, and we have to take care in the very first incidence. Now, this is a beautiful paper. We know sublay placement is the best. Holihan did in 2015. He combined all the papers, and we know there are different layers of mesh placement. Same in other non-obese patients as well. In obesity, this plane is the best. And when you ask me, our choice is always MIS and always sublay if possible, not for small hernia, but moderate and larger size hernias. In obesity, if you are dealing with 2 centimeter hernia in a non-obese patient, the treatment is different. But when you are dealing with a 2 centimeter hernia in an obese patient, it is not the size which matter. Your subcutaneous fat, your surface area of the abdominal wall. So these all factors should be combined when you are planning to operate in an obese patient, and it's a very important factor. Now, number of previous repairs. Recurrence, you are dealing with recurrence. Try to don't go in the same plane where the earlier surgeon has gone. Now, you can see in this video that there is recurrence on lateral side is only mesh is placed in only repair. So you have to go in some different plane for the mesh placement. When we talk about complications, complication can be early or late. I am not going to deal with medical complications. But yes, for complications, we always now talk about ETEPs. Sublay repairs, laparoscopic repairs. And this anatomy, hand anatomy, you should very, very well understand, because the neurovascular bundle runs in between internal oblique and transversus abdominis. And this is the basic concept any abdominal walls hernia surgeon should know. Because most of the newer complication which we see from the new young surgeons is damage of this neurovascular bundle. This is a short clip of neurovascular bundle. You can see this is IEA and the lateral, the neurovascular bundles. Now we'll inject ICG, and you can see how beautifully it will blow like a light. Now ICG has been injected. And this anatomy, every abdominal wall surgeon has to understand. And you can see the beautiful neurovascular bundles. And these all neurovascular bundles should be shaved, whether you are doing ETEP Reeve Stopa or you are doing ETEP TAR. So this is just to demonstrate. It is not required in each and every case, but you have to understand this anatomy before you venture into abdominal wall reconstruction, may it be obese or non-obese patient. Now see, this patient has been operated by one of my friends, just 2 centimeter hernia. And video is not running?
Please go.
Oh, sorry, video is not running, but you can see on this side, right side, the rectus muscle is totally devascularized. Video is not running, but this damage is unrepairable damage, and that's why you should understand the neurovascular bundle. Now, second thing, when you are venturing into ETEP Reeve Stopa or TAR, this is my own case when I started in 2017. And see, this damage of linea alba is very common when you start AWR surgeries. But the problem is, if they have damage, you have to give proper respect to them. You have to suture it and then place a mesh. Definitely mesh is going to give you additional safety. But this should not be missed. Otherwise, you are going to have a recurrences 100% in the area where you have damaged the linea alba. PRS rupture. This is a case, my own case, where we have done bilateral TAR. Now, see, probably the posterior sheath would be in tension, and that's why you can see the posterior sheath has given way. So in this type of situation, if it happens to you, the only savior is IPOM, which we did in this patient. So tension less repair, which is very important, and you have to understand this. So now you can see the defect. It is day 2 only. Day 2, the patient might be because of cough or whatever the reason, it has recurred, and you have only IPOM plus, which is a savior. Now, again, a patient where a surgeon has done bilateral TAR. And if you can see in the operative report, he has done ETEP, Reeve Stopa, bilateral TAR, and the mesh which he has placed is 15 into 15 centimeter. How it is possible? The mesh is definitely, the defect is definitely undercovered. And if you are going to do like this, recurrence is a must. See, this is the recurrence. And managing these patients are very challenging. Now, large seroma, this is again my own case where we have placed a mesh, and you can see very beautiful biofilm form. You can see the mesh on the base. These cases, your mesh has to be out, and they are very unfortunate cases. But yes, if this happens, they are formed seroma. How much aspiration you do, they are not going to heal. You have to remove the whole seroma mass, and then definitely some secondary procedures. Now, this is a video from one of my friends. This is totally sterilization failure. You can see the mesh which is floating in the ETEP plane. So this is how you should avoid, we always stress on sterilization in hernia surgery. And that is there if it is breached. Now when you have injured a bowel, very beautifully discussed by the earlier speakers, if it is CDC class 1, if you have injured the bowel, there is no harm in placing synthetic mesh. We have enough evidence to prove that. Class 2, if there is no spillage, you can use a synthetic mesh. But for class 3 or class 4, you have to abandon with suture repair. Or if you want, you can use a biological mesh, which is a costly affair. So when I was searching for literature, this is the literature when you are doing recent lab ETEP procedures. Not a big deal, but they have total collected 13 studies. No major complication, but SSI rates are very less. So our choice is always, as I said, minimal access and ETEP Reeve Stopa in moderate and larger hernias. So in conclusion, every patient needs individualized approach. We need to understand the obesity, preoperative factor, pre-optimization, and then we should deal a patient. Sublab placement is the best, and continued research is needed in this field. Thank you very much.
Discussion and question, yeah.
Discussion. My first question would be, in bariatric metabolic surgery, would you close trocar defects? think on your own. If you say, yes, I would close defects, why you don't close hernias? And I give you a very nice example of what can happen, because hernia surgery is a specialty on its own, and that was perfectly described by the emergency cases. Perfectly described by Shashang Shah was also what is favored, what is not favored. Okay, but I give you an example of a patient that was admitted to my department in the early morning with an open abdomen. So the center where they performed gastric sleeve resection, they ignored the recurrent hernia because the patient had the hernia forever, and now he is super obese. His BMI was 55 or 56. And the patient got 2 days after incarcerated hernia. It was an emergency surgery, but the surgeon couldn't close the abdomen wall because of the obesity. So what they did is just they put a sterile gauze on the abdomen and sent the patients to my department. So what I had to do then was to deal with really a very challenging case. You can imagine with VAC therapy, 2 months of changing the VAC, doing biomesh, abdominal wall reconstruction, and at the end, the closure after 2 months. Just an idea how difficult it could be to close a defect on the abdominal ceiling when you are not familiar with suturing properly and then put the mesh properly, because just to put the mesh and stick it with staples is a malpractice. That will create the recurrence 100%. Anyway, just think about before you operate. And if you think, document why you did make this decision. Because I hate those algorithms. I hate statistics with 400,000 patients. You don't know, is this surgeon that treated those patients, is this a hernia surgeon? Was this an emergency case? Was this a simple umbilical hernia, primary, recurrent? How many recurrences? What was the BMI? Definitely in this specific case, we just have statistics, and that is bullshit. This is something which is interesting to read, but you have to make a decision individually on a patient, BMI 50, with a recurrent hernia, who had already a mesh, etc. What will you do? And if you make a decision, document. That's my comment.
Emanuele, I believe that Dr. Lomenzo is the right person that can answer this question. And this aspect, of course, that is aspect that is fight between the real life and numbers, of course. Yeah.
Yes, thank you. That's an excellent point that you're bringing up, and I think we need to extrapolate our data from the experience in bariatric surgery. It's been very well shown now from many studies that when you use a radial trocar that is blunt and doesn't have a cutting tip, and you're off the midline, you're in the upper abdomen, most of the times we don't close the trocar sites. However, if you're extracting a specimen, like in the case of a sleeve gastrectomy, obviously you close the trocar because that's a different story. A hernia, of course, is different. Even a small hernia, the opening in the skin and the opening in the fascia, they're aligned. They're not like in a trocar, in a separate, they're not in separate areas. So closing a hernia, obviously, is a different story. So obviously, we close trocar sites if there's a specimen extraction. A word of caution, however, is if you go supraumbilically and you have a small umbilical hernia, sometimes you end up with a very small bridge of fascia. And although it's a blunt entry, the fact that it's a very small ridge of fascia through an existing umbilical hernia, that trocar site should be closed.
Thank you, Emanuele. Very, very nice. I agree totally on this. And you are probably the surgeon that go in the same times. Of course, you are a hernia surgeon and bariatric surgeon, so you can manage at the same time and have the rational view, of course. But Michele,
Okay.
probably Umberto.
Umberto Bracare,
Ruggero, you want to do something? Okay, okay,
who speak
Ruggero.
about
This topic, this specific topic, okay.
Yeah, I just want to connect what they just said because I think it's a very important point of view. I mean, for the patients, it's not very easy to find a surgeon who is a bariatric surgeon and the hernia surgeon. Sometimes they, you know, they go to one person who has not experienced to do both. And we know that hernia surgery now is so updated, and I'm not saying it's less important or less
or more
difficult than bariatric surgery, but there are some aspects which are typical of hernia surgery. The pathophysiology of the hernia, if it's recurrence or it's a primary hernia, if there is a loss of domain, what are the state of the muscles or the skin, but also the techniques, you know. I mean, there are some techniques that are so specific that only hernia surgeon can do, TAR, posterior component separation, and so on, and the materials. So the very important point of view, in my opinion, is that there must be a strong collaboration between hernia surgeon and bariatric surgeon, and that's could reconnect what you just said.
Thank you, Roger. Very nice talk.
Umberto.
Umberto, one other thing that we have to talk about, because you have seen the presentation from Rossana. So what is your opinion? Because the final theme and the final aim is it possible that the robotic approach takes some advantages for the contemporary repair of abdominal wall hernia and bariatric surgery? So in other words, is this an improvement using robotic approach or not?
Well, for me it's very difficult because I am not a bariatric surgeon. So during the presentation I try to remember what I do during, for example, reversal Hartmann. And sometimes we have a lot of defects on the midline during reversal Hartmann. And we prefer to do not put any kind of mesh in this kind of operation. And I think that it should be the same, in my opinion, from an abdominal wall surgeon's point of view. I think that it should be avoid any kind of mesh during other kind of procedures. I think that probably it's absolutely necessary to close the defect and to postpone any kind of more complex abdominal wall surgery in the second moment. Yeah. This is my idea.
Thank you very much.
I have only
one question. Even a question from the audience. If someone from the audience wants to have a question with the discussant or with the previous speaker, can raise the hands, and so we give the microphone.
I have one question to all bariatric surgeons. I think that the majority of this kind of patient need also an abdominoplasty.
At the end.
At the end.
At the end.
So if they have also some midline defects, why we have to prefer a minimal invasive approach?
So, Dr. Rajesh or Dr. Miller, Dr. Rajesh, or Dr. Agraval. Is the Dr. Agraval present here? Dr. Agraval?
The best comment was from sir that every patient is different in this type of scenario. When you want to club the abdominoplasty with hernia repair, who is telling why to do MIS? Then there is no option. You have to do open surgery, definitely. But when we talk about the outcomes of obesity and hernia surgery, when you are not planning, see, in our series we have done open surgeries where there is multiple scars, where there is multiple recurrences, where it is very difficult to approach into that plane. So there you have to plan. So every patient is different. But on an average, when we talk in a broad spectrum, MIS is best in obesity surgery. Sublay placement is best in obesity surgery because in non-obese patient, we talk about 4 centimeter cover. Sir was talking about IPOM. We know 4 centimeter every side is okay in a non-obese patient, but that is not correct in obese patient. A 2-centimeter hernia is different in a non-obese patient. That is quite different in an obese patient of 55 BMI. You have to cover 8 centimeter every side if you want to, if you don't want to have recurrences.
Okay, thank you. Diego,
Thank you very much. Diego.
Firstly, I would like to thank the chairs for the kind invitation. I'm sorry that I arrived at the end of the session because I was unable to leave the OR explained on time. But I have seen the end of the lecture of Rossana Berta and all the last speaker. And I have a question for Rossana and also a comment for the last lecture. For Rossana, do you think, Rossana, that for parastomal hernia in an obese patient, robotic repair could be advantageous? And if your answer is yes, what kind of technique do you suggest to adopt? And for the last speaker, you had an excellent lecture concerning recurrence and complication, and you have listed all the kind of causes of recurrences. But I think that today and now it's time to point out that we as surgeons, the surgeon as a risk factor. The surgeon for the choice of technique, for the timing, the choice of timing, for the mesh used, for the technique. And I think that this is the most important thing to discuss about concerning complication and recurrence rate. Thank you.
Diego, I don't know if you have read my last editorial on this topic that I've talked about the tailored surgeon. Not the tailored surgery, but the tailored surgeon. Very important topic in my vision. So the surgeon has to be tailored for the procedure that he has to do. And this is exactly this, but please.
I have read a very interesting paper that is the surgeon as a risk factor.
Yeah, the tailored surgeons. Yeah.
Okay.
Roberta, very short answer.
Yes, I think that the robotic approach and the Pauli technique is the best approach for parastomal hernia. Can be considered a lateral hernia, so I think that robot is the best option for this kind of hernia. And in obese patient, is perfect, I think.
And Rajesh, last very short answer.
I 100% I agree with you, sir. Surgeon is a very important risk factor. That's why I said timing is, when you said timing is important, type of mesh you are using is important, type of coverage you are using is important, your knowledge of the anatomy is very important. Of course, surgeon is one of the very important factor. I understand, I agree with you.
This is the concept of favorable and not favorable. Among them, even the surgeon has to be favorable surgeon or not favorable surgeon. This is something very important to consider, I believe. We have some questions from the floor. If not, we can conclude. I believe that Michele and I, we talked about, so at the end, the final message is that it's possible or it's not possible, when it's possible to do in the same time. So of course, in emergency surgery, Fabio Campanile has talked about this. In emergency surgery, no doubts, we have to solve the question. When it's not emergency surgery, but it's potentially emergency surgery, incarcerated is debatable. And the debatable in the ratio between favorable approach, approach, not favorable approach in both for hernia and for morbid obesity. And so sometimes, honestly, our consideration is that it is possible to do before the weight loss, dietetic weight loss, medical weight loss, or surgical weight loss is much better than do it in the same time. So you can achieve much more favorable results if you do the staged repair, of course. But this is something that is not really demonstrated from the literature and from the guidelines. But usually the guidelines are always the guidelines, our suggestion is not the Bible. And I believe that this could be one of my final word, but I won't leave the talk to Michele for the conclusion.
Oh, thank you very much. The conclusion is very easy for me. There is a difference between obesity patients and non-obesity patients. But in hernia repair, I don't see so big difference in the technical and in the surgical approach. il buon senso, the good,
sense of father of family.
A good sense of father of family will guide the surgeon, first thing. Second thing, my consideration is that in obesity patients there is also, again, a place to direct suture because the risk of infection, IFSC, is important, and in some case the not use prosthesis is a good solution. Then I understand that biological prosthesis is have just a little place in this surgery, also in emergency condition. And this is, for me, a new concept, a new idea to consider. So, every presentation will be, is very interesting. Compliments to all speakers, and thank you to stay with us.
Very well. We are in time, so we can leave the room. Thank you very much.
Bye.
Oh, yes, of course.
Picture.